Great. Well, welcome everybody to this month's Health Policy Grand Rounds here at the Philip R. Lee Institute for Health Policy Studies. We are in person in Mission Hall in room 2103 if any of you are on campus and want to come on in. And then we also are obviously on Zoom. We are going to try doing this without the microphone just because it is a little distracting in the room. However, if any of you online are having trouble hearing, please put something in the Q&A and we will hand our speaker the microphone, or me the microphone. So I am really excited that we have Professor Jennifer Oliva here today. She is from the University of California School of Law, San Francisco, College of the Law, San Francisco. It's just renamed. I'm still working on it.
Nobody knows.
No.
That's not you, Joe.
Which was until recently known officially as UC Hastings. They're in a transitional phase on all the naming. We are really excited to have Professor Oliva here. She is also engaged in the UCSF UC Law SF Consortium on Law, Science, and Health Policy, and has done some very interesting work. Just a very short background on her bio. She is an Army veteran. She attended West Point and then earned a Rhodes Scholarship and went to Oxford for a master's degree. After completing that, she had her military service over 5 years, I believe. And then she went to Georgetown Law School on a Truman Scholarship. After completing law school, she was a clerk in appellate courts in Washington. She did other legal practice work as well as academic work and came to UC Hastings, I guess, or UC College of Law about, it was UC Hastings when you came about a year ago,
That's
right?
That's right.
About 1 year ago.
That place over there. That's right.
I am very excited about this topic. It is related to prescription drug surveillance and issues related to the opioid crisis, the capacity of clinicians to care for people who have both opioid use disorders and significant pain management issues. And I am really looking forward to this talk. So I'm going to hand it over to our speaker. Thanks for being here.
Thanks for having me, and thanks for that very generous introduction, as well as the struggle is real with the school name, which you can see is quite long, and that's a story that we have to tell for another day. So I am going today to talk about two subjects near and dear to my heart. I actually primarily write in drug policy, and I write in drug policy across health and criminal law, amongst other areas. And so I'm going to talk about prescription drug monitoring programs, which I've written several articles about, as well as a case that I had the privilege of being an amici, meaning me and another law professor wrote a brief in the Supreme Court of the United States, two briefs actually, one at certiorari stage, which I'll talk about, then one on the merits, on behalf of the health law professors in the United States. And that case was decided this summer by the United States Supreme Court with very little fanfare because there were other things going on in the Supreme Court this summer. There were a bunch of controversial cases decided around the same time, including very famously Dobbs, West Virginia versus EPA, and other cases that have made the Hall of Fames of legal history already. But I'll tell you a little about that case. It was actually a 9-0 decision, which is really weird. The court actually completely agreed with us. And I'll talk about that at the end and then take questions. So here's my agenda. I always like to put it up for people. I'm going to kind of march you through something that you think you know a lot about, but I want to make sure we're all on the same page to set the table, which is the sort of like evolution of this overdose or drug poisoning crisis that we've had going on in the United States now. It pains me to say now for more than 2 decades. I'm then going to talk about prescription drug monitoring programs, and please accept at this stage of the conversation that I will have a hard time not calling them PDMPs. So when I say PDMPs, that's what I mean. And this risk scoring that they do. I'm going to apply a bit of a data science critique to that risk scoring and tell you what all my concerns about them are. Then I'm going to ask and answer the question, do PDMPs improve health outcomes? Because that's what we care about. My answer to that, spoiler alert, is no, they don't even measure them. And then I'm going to talk about what kind of legal intervention I think will be best in this context to get us back on course. And like I said to you, I'll talk about the Rwanda case a little bit, and then I really want to hear from you and the questions that you have. So let's start with a brief overview of this drug poisoning crisis. Now, I'm sure you all have seen this chart before, but just in case you haven't, I'm going to leave this up for a little bit while I talk through it. The first wave of the current crisis, started around 1999, and you could go back even further, but it's frequently attributed, at least in mass media, to the prescribing of OxyContin, which the FDA approved to treat chronic pain in 1995. And no one's heard about OxyContin or the Sacklers, they probably have not read U.S. news for the last 20 years. Several things of note occurred during this first wave. First, prescription opioids were widely demonized due to escalating overdose deaths. Second, the Drug Enforcement Administration and the Federal Department of Justice began investigating and prosecuting prescribers and dispensers for their opioid-related practices. And to aid in that effort, the DEA provided mass funding to the states to develop prescription drug monitoring programs, which is what I'm talking about today. Third, in response to this heightened law enforcement surveillance, prescribers began to get out of the pain management business and started to significantly limit their opioid prescribing. This takes us to wave 2 of the crisis, an approximately 3-year period. You can see there the purple box from about 2010 to 2013. Here, prescription drug overdose deaths begin to stabilize. Peak prescribing is around 2010, but we witness a rise in heroin poisoning fatalities during this period. Illicit synthetic opioids like fentanyl quickly replaced heroin as the dominant drivers of American overdose deaths in wave 3, which you can see we start to notice it in around 2013. Unfortunately, that particular trend, this wave 3 trend, has continued to date and worsened. Now, what we see across all 3 of these waves of the crisis is the illicit drug market, heroin and fentanyl, behaving consistent with what drug researchers describe as the iron wall of prohibition. Richard Cohen coined that term in 1986, and it stands for the proposition that as law enforcement becomes more intense, the potency of prohibited drugs increases. Cohen puts it this way when he talks to folks: the harder the enforcement, the harder the drug. Heroin's more potent than prescription opioids, and fentanyl is up to 1,000 times more powerful than heroin. And this is the first time we've seen this. It was predictable. We witnessed a similar dynamic during alcohol prohibition, where many Americans used to get up in the morning and have your beer, your cider, switch to high-proof spirits, right, and hard liquor because it was easier to smuggle, right? So we've seen this before. The situation continues to deteriorate. You can super see that on the end of this chart. We had a record-setting year in 2020 for the most overdose deaths ever recorded in a 12-month period, and we beat that again in 2021. We're on about a 6-month lag, and it pains me to say this, and knowing exactly what our numbers are because of the way reporting schemes work in the United States. But so far, 2022 doesn't look good, and we may end up having another record year. All right, there's San Francisco. This slide may be hard to see if you're not on the Zoom, and for the people in the room, and I apologize about this, but what this shows us is different categories of opioid related overdose deaths. Those are the colored lines, like the purple, the green, the orange, the blue, okay? Those lines are laid over these gray bars, right? And the bars represent the rate of opioid prescribing over time. And what you can see here is that opioid prescribing is at its lowest level in decades. In fact, we're back to around 1993 levels right now of opioid prescribing. However, look at the overdose deaths. That purple line right at the top is total opioid-related overdose deaths. So there's at least some kind of opioid in the tox report at the time of autopsy. That's all I'm saying. There could be all kinds of other things going on. All right, the green line there is illicit fentanyl deaths. So you can see that taking up the bulk of that vertical chart there. The yellow line's heroin, and that white line that's kind of staggering along at the bottom, which I hope is the one that you can see, is prescription opioids. And you can see that it's unfortunately fairly consistent over time, no matter what the level of prescribing is. I'm going to talk about that more. I put this chart up because it's a little local flavor. This is San Francisco / San Francisco County. And that red line up there is county overdose deaths from 2006 to 2018. You can see how that's gone. And then the blue line is prescribing in San Francisco. So this is, I just always go to the county whenever I'm giving this talk to show you that this is very consistent with the overall US data that I just showed you. It's never, ever been off the mark. And there you go. All right, now let's talk about these prescription drug monitoring programs, which I don't know how many people have heard of them, but I want to give you a little background. During the onset of the overdose crisis, only a small number of states in America have PDMPs, about 8, okay? The state databases were passive surveillance and collection systems, and they usually limited their collection to Schedule II drugs. And so for anybody who knows anything about how the DEA does scheduling, those are the drugs highest on the schedule that can actually be prescribed. Schedule I drugs are actually illicit drugs, right? Like at the federal level, marijuana, LSD, we could go on. But Schedule II drugs, all right? The old school PDMPs were not powered by AI software. They weren't in these big databases like the modern AI-powered systems I'm going to talk about today. Now, as I already mentioned, during the early aughts, federal law enforcement incentivized the states to adopt and expand PDMPs to facilitate opioid prescribing surveillance. Okay. The important takeaway here is that PDMPs were funded by, cannot say this enough, funded by and designed as law enforcement investigatory tools, not for public health surveillance. They were not developed as clinical diagnostic tools at inception. So here's how modern PDMPs work. Anytime a patient receives a prescription from their prescriber for a monitored drug, so a drug that's actually surveilled by this system, the pharmacist is required to log that transaction at the point of dispensing, and at that moment enters a litany of information about the prescription, the dispenser, the prescriber, and the patient. Okay. Now, most Americans are unaware that PDMPs even exist. I give this talk a lot, and I always ask people the following question just to kind of get a sense. So I'll do it in the room, but you can also feel free to participate on Zoom. How many of you have had a dog or cat neutered or spayed over, say, the last 15 years? Okay, you're in the PDMP. All right. And why is that? Well, it's standard of care for veterinarians to dispense small dose opioids to animals after these kinds of surgeries. And let's face the facts, if your dog or cat is anything like my 6-year-old Boston Terrier, Eva, they have a real struggle at the CVS getting that prescription filled by themselves, no matter their level of competency. So we fill the prescription for them. And what happens at the time? That prescription actually goes under our name as well. So that the PDMP will log you in then as having filled an opioid prescription, and you will now be a permanent member of your local PDMP. So I just want to make sure everybody knows that. Today's PDMPs collect voluminous data from more and more questionable sources. I'm going to complain about that for like the next 4 slides. They also monitor and surveil a much larger swath of prescription drugs than their predecessors did. So again, I just told you, these things were almost exclusively limited to Schedule II substances, right, at the time. That was true in the state of California for sure. That has the oldest continuously running PDMP in the country, all right? Now you see almost all states, and I looked this up, it's like 38 states surveil Schedules 2 through 5, plus quotes unquote other drugs is concerned, meaning other drugs that aren't even on the schedule. So that's the vast majority. And about 9 are limited to 2 through 5. But there's no state in the United States out of all 50 that have these systems that are limited still to Schedule II drugs. Modern PDMPs use algorithmic software to mine through this voluminous data that they collect, and they generate things called risk scores and red flags. These risk scores and red flags purport to identify for the prescriber and the dispenser patients who are at risk for drug diversion, opioid use disorder, prescription drug misuse in any way, shape, or form you can imagine. Now, you have to trust me when I tell you the next thing. The dominant PDMP software company in the United States is called Bamboo Health. All right, it's worse than that. It gets worse. Ironically enough, Bamboo Health decided to call its PDMP software platform NarxCare, and the risk scores that it generates and reports on people, NARC scores.
Nice.
That was a voluntary decision. You cannot make that up. All right. So there's NARC score criteria in Bamboo Health, PDMP aware. You can see I'm not lying about this. The District of Columbia and 42 states use NarxCare and Bamboo Health system. California is actually one of the outliers. California uses its old school system housed in the California Attorney General's office, so it has its own system. But I'm going to talk about NarxCare because that's the predominant, that's the major platform. NarxCare's signature deliverables are its risk scoring algorithms, which assess each patient at a level of risk, right, for misuse. Now, it's important to note here before I tell you about the criteria that I actually can't tell you exactly what data NarxCare collects or how NarxCare algorithms actually weigh and value the various data points or proxies it uses to generate these risk scores. That's because Bamboo Health is a private company, and Bamboo Health claims that its algorithm is proprietary and protected by commercial trade secret laws in the United States. So they do, even though this is used in all 50 states, or these kinds of things are used in all 50 states by clinicians on a daily basis, the clinicians themselves could not possibly tell you exactly what's going on behind the scenes. I've tried to sneak into Bamboo Health. I've tried everything under the sun to figure this out. And let me tell you something, they're sticky about the fact that that this is protected by trade secret laws. So there are numerous criteria, however, that Bamboo Health has been upfront about in its marketing material, publicly disclosed. Those are the ones that I'm going to tell you about. So the NarxCare criteria that I know about are as follows: the number of providers and pharmacies that a patient uses, the amount and strength of the medication prescribed, overlapping and potentiating medications, and the distance a patient has to travel from their address of record in the PDMP, whenever it was entered by that first pharmacist, to their providers and dispensers. Okay, let's pause for a minute and just think about that distance traveled metric. Bamboo's theory is that the further you have to travel from your home of record to either see your providers or have your medication dispensed, the more likely it is your doctor or pharmacy shopping, more likely it is you have opioid use disorder. I make a big argument in my papers that this theory proves way too much because there are numerous benign reasons why patients might have to travel great distances to fill opioid prescriptions. Their closest provider may have retired or like gone out of the business, as I told you. Lots of people have done that. They may have been medication discontinued or abandoned by the provider closest to their home for a number of reasons. They may have a rare condition that requires them to see a specialist in another state. They may live in a rural location or a healthcare desert, right? So there are any number of reasons why, especially people with really complex rare conditions, would have to travel further and further away. All right, the NarxCare.
Can I ask just like a
absolutely
question? Do people update, like for every prescription that gets dispensed, does your address get updated, or does it just whatever got put in the first time you ever spelled something?
So one of the things first of all, the answer is that depends. Some pharmacists, right, will update if they know or are aware of the fact that this should be updated. If they might say to you, oh, are you the John Smith at 342, South Street? But others don't. They just assume that's close enough for government work. You probably are from there. This doesn't seem odd to me. They're not thinking another state or any place real far away, and they never ask. Patients don't provide any information. That's one of the things you'll hear me complain about throughout this conversation is patients don't get to see these reports or check on them. So there's no way for a patient to go, hey, actually, I moved 2 counties over because I changed job or whatever it was. I got married or my kids left the school. I had to get out of that expensive property tax because they left the house. There's a million reasons why people move around. So it's an excellent question, but it all depends on the pharmacist's practice. Do they think that they should ask when they log into the PDMP based on whatever they're thinking? That's too far. That seems off, or it seems odd. So the answer is, unfortunately, as the legal answer often is, it depends.
So these scores that are attached to individual patients,
yes,
do the prescribing clinicians see those?
Yep, and I'm going to show you the reports.
So that seems
coming down the pike.
So it seems to me then you might have a patient who's getting flagged because of bullet number 2 or bullet number 3.
Yep.
And maybe is cause for concern.
Right.
But a single clinician might then say, oh, I don't like this person's NARC score.
That's right.
I'm going to cut them off and tell them they have to go see a specialist.
That's right.
And the patient might say, all right, I'm going to go see a specialist. Thank you for recommending that I do that. And now suddenly they're traveling and get flagged on other things. So that.
Well, and this happens a lot at pharmacies too. So first of all, I don't know what you guys know about controlled substances and how pharmacies work, but they only order a very limited amount because they don't want to get flagged by the DEA as like being up to stuff, right? So ARCOS and the DEA track this. So you might come into the pharmacy on any given day and they're like, we're out of whatever XYZ opioid because we only ever keep this much of it we don't want anything to look suspicious to the DEA. So then you go to the next pharmacy and the next pharmacy and the next pharmacy. So a lot of the practices behind the scenes that narcs care actually penalizes you for are like standard care practice medicine things. And I'm going to talk about that in a minute with academic medical centers. So I really want you guys to, I appreciate these questions. I really want you guys to be aware of it. So I put up method of payment. Let's talk about that one real quick too. I really complain about this. The NARC score criteria, and they're upfront about this. This is right on the website. It actually penalizes you if your method of payment is by credit card or cash instead of with like a third party payer like insurance. Okay, so this factor necessarily, and no one can give me a good answer to this, punishes individuals who are under or uninsured for no good reason except for they're under or uninsured, right? So now you imagine now we're piling on, right? We've got the rural patient, right, that has to travel, that lives in a healthcare desert, that has to travel pretty far to get treatment or see a specialist, maybe even across state lines. They go to the first pharmacy, they're tapped out. It's a rural small place. They have to travel even further to another county to another pharmacy to get, and then their method of payment is cash or credit card because they are uninsured. That person's NARC score is starting to go out, through the roof. Additional criteria that might concern you that Bamboo began to incorporate in PDMPs include patient sexual abuse and trauma histories, medical marijuana records, and most disgracefully from the legal system side, criminal records. Now, one can imagine how those criteria disproportionately impact women and racial minorities, right? Women are more likely to report and seek medical assistance for sexual abuse and trauma. That's its own problem in the legal system, but that happens to be true. And it goes without saying that racial minorities who misuse drugs at virtually identical rates as their white counterparts are much, much, much more likely to have a criminal arrest or conviction. Now, in the United States, what data scientists will tell you is that criminal records are effectively a proxy for race. That's how disparate it is on that kind of stuff. It's also important to pause for a minute and ask hard questions about the data that NARCS Clear doesn't collect, like the patient's diagnosis or condition. So I ask you guys, how is it possible for the algorithm to know how to weigh or measure whether the amount, strength, and type of my medication is appropriate for me when it has no idea about my underlying healthcare condition or conditions? This is not a hypothetical question. A recent study found that 20% of patients at PDMPs were most likely to flag as doctor shoppers have what? Stage 4 cancer. Those patients likely have elevated risk scores due to the fact that they see what? Multiple providers. It's the essential nature of oncology practice for people to have multiple specialists. And notwithstanding this fact, and that this has been told to Bamboo Health, at least by me, I can tell you for sure, there's no indication that they have adjusted their risk score or willing to adjust their risk scores to address this.
Well, and also if stage 4, if you're stage 4, stage 5, if you're terminal, standard practice is to manage your pain fairly aggressively.
It's a standard of care to manage the pain. We've had people who are in hospice who had, and I'll be honest with you, these are mostly older ladies who had gotten it towards the end of life before they went to hospice and they're rescuing really old and beat down cats who had gotten a lot of opioids prescribed to them because they were taking care of these cats that nobody else would take care of that were like 18 years old. And they were refused opioids in hospice care because of their NARCS care. This is why I got onto this kick, because you cannot I couldn't believe this when I first looked at it, you guys, honestly. So here's my summary of why I hate NARCS care. It's secret and proprietary. So again, like it resists external validation, although I'm going to tell you in a minute, we've got people who have gone to the task. All right. It's never been externally validated by them or the FDA or anybody else that may have some kind of regulatory oversight. They report to measure risk. Is this prescription going to push you down the road towards drug misuse, diversion, or is it going to help you out? Experts are crappy at making that kind of an assessment. Okay, so it purports to measure risk, it's hard to measure. Disparately impacts marginalized groups, punishes patients for things outside their control, like their insurance status, their resources, where they live, etc., their healthcare conditions. And then let me pause on this one because I think you guys will appreciate it more than most audiences I speak to. HDCS, our healthcare delivery system hyper incentivizes folks to utilize these risk scores or reliance on these risk scores that are facing them. Why? It's quick and objective. You only have a few minutes with patients. That's all the payer or the third party insurer is going to pay for. And at the same time, if you just do what Narcs Care tells you without looking deeper, not only do you save time, make that third party payer happy, get to the next patient, you avoid criminal and regulatory oversight, because that's what your board is looking at. That's what your local police is looking at. That's what the DEA is looking at. So there's no reason not to listen to Narcs Care to save yourself. The only reason not to listen to Narcs Care is because you know better and you're a good person. But you're putting yourself at tremendous risk, right? And all sorts of other things if you do that. So I feel sorry for providers. So my legal assessment is that Narcs Care aggravates an already atrocious situation. All right, so I'm going to show you. I'm glad you guys asked about this. So this is a, you can see the top Cameron test patient. Again, I've tried everything I can to get in Narcs Care. They will not let me in.
They know you.
So I go to the trainings when they'll let me get in. They don't ask you for like a DA number. So they'll just let some people go to the trainings, and I take as many screenshots and things as I can. Huh. You'll see what it does here. Here are the 4 risk scores. They give you a narcotic score, a sedative score, a stimulant score, and then your overall risk score. You can see in this particular report over on the side, they use exclamation points in a little red box. Sometimes they just use a big red flag. And the real fancy ones have a red flag, like it actually waves. It's actually like motion activated on the screen. So you really can't miss it by the score. You can have it, by the way, just so you know, a narcotic score if you've never been prescribed an opioid, because if you've been prescribed something like a benzodiazepine or something in another category that is like counterindicated to have with an opioid, they give you a narcotic score anyway, so that the prescriber knows. The idea is a prescriber will like go, oh, there's a narcotic score, I should double check everything. So technically speaking, you can build up your narcotic score without ever having been prescribed a narcotic. You're also going to have a narcotic score for your elderly or decrepit cat, like I just said, or your dog or whatever. So overall overdose risk scores, they just flag you at a certain point, period, full stop. And I just wanted you to see that. But here's what's more important. Here's a prescriber report card. And I know that there's no way you can see everything on there, but I just didn't know the appropriate way to cut it off. But that report card you see on the on the side and the things pulled out, what happens is you come to work in the morning. You're a prescriber. Come to work in the morning and you got an email. And the email says you've been flagged. The system has flagged you. And that means we've forwarded this report to your professional licensing board. They forward a report to professional licensing board. The system automatically forward a report to law enforcement in some states. Okay. So you see this, and what you know is I've been flagged as an outlier for some reason. My prescribing's too high. I have too many patients that are flagged, whatever's going on. So my question to you is, what would you do? Would you prescribe an opioid to the next patient you treated, even if you are absolutely certain it was medically necessary? Or would you make non-medically indicated adjustments to your prescribing habits to avoid triggering a law enforcement investigation and to get out of being on this list? I think you all probably know how this usually goes. So here's a question I told you I would answer. Do PDMPs improve health outcomes? Well, as I explained in my work, PDMPs do not measure patient health outcomes. Narcs score does not evaluate whether clinical prescribing decisions like improve or worsen patients' pain, mental health, daily functioning,
actual overdosing.
That's right. That's absolutely right. Quality of life. Did they go to the ER? She's absolutely right. Did you show up at the ER time and time and time again because you were deprescribed? How did that impact you? Narcs Care does not flag prescribers or send clinicians an alert when a medication discontinued or a forced favored patient dies by suicide or is admitted to an emergency room with debilitating pain or depression. Narcs Care does not track and assess patient outcomes because the platform's success is not measured on those results. Algorithms measure what they care about. And this algorithm cares about one thing and one thing only: the rate of opioid prescribing in the population that it's measuring. That's it.
So there are some studies and states that have sent letters to clinicians when one of their patients dies of an overdose.
Yep.
If the clinician was attached to any prescriptions, but then if the clinician cut them off,
right,
they're not going to get a letter when the patient turned to fentanyl on the street.
They literally have no real-time mechanism, and people are spending all this money for this system. Like, one thing it could do is give prescribers feedback, right? And like, and it's one thing that it refuses to do, because it only cares about giving feedback to the regulatory oversight authority, like the prescribing boards, the board of pharmacy, the board of medicine, and police, so that they can crack down on prescribers. That's what the system cares about, and we know that because that's what the system does. So what the other thing, so I will do want to show you what PDMPs have been good at. They have been A+, top notch, 10s across the board in diving at reducing opioid prescribing. Like I said, we're down in the 1993 levels here that were the precursor to this. So there's no question that every study that has looked at PDMPs says they push down, they de-incentivize prescribing, right? Because you don't want to go to prison and all this. Oops, sorry. And here we go. I've said this a million times and I was holding this one back. You can see the total prescriptions in millions, prescriptions for US population there, and you can see we're back at 1992, 93 levels. And that's from the FDA. So, all right. So reducing prescribing. They changed prescriber behavior. This is known if you study it quantitatively or qualitatively, because prescribers are interviewed anonymously frequently about this. Here's what they say. I feel incentivized to force and rapid taper patients to get them out of the practice, patient abandonment. And also there have been whole healthcare systems. Seattle's Children's Hospital just did this. This happens all the time, where they just have a literally written policy that says we won't initiate or treat new pain patients. They've changed dispenser behavior. Dispensers often, even when they have opioids in the back, refuse to fill to certain people, and that causes them to have to run around. And they've changed patient behavior, and this is the most dangerous thing. It's caused patients to constantly seek new providers, run around to these dispensers. A lot of people are so humiliated in this situation that they avoid or forego treatment. But the worst possible thing that can happen, and the research in addiction medicine is known on this, if someone actually does have an inclination to misuse opioids and they go in for an acute episode in the hospital, even if they have a history of opioid use disorder and you refuse to treat their pain, that's when they're at highest risk. Besides coming out of prison, that's the other time you're at highest risk of relapsing. Those aren't my studies, those are facts. So when we have a system that incentivizes that exact behavior in medicine, we have a system that is really pushing people to the edge here to switch to dangerous illicit substances to deal or relapse if they've had previous opioid use disorder. All right. So we've gained a much clearer picture of PDMP risk studies due to what I'm going to call heroic efforts of Dr. Angela Kilby. Dr. Kilby is a health economist at Northeastern University. And literally, I have a picture of her in my slideshow. I have a picture of her up over my bed. She's literally one of my favorite people. Maya Salovitz, who is an amazing journalist who works for the New York Times now, wrote this article looking at Dr. Kilby's work. She's fantastic. She's also a person who in the past had heroin use disorder, so she has personal lived experience. She looked at Kilby, built the algorithm, looked at huge claims database, and tried to recreate a narcs care. And here's what the article says. Look, it was wrong, guys, 89% of the time. Now, I tell people this, especially in law, because, we're all lawyers because we're terrible at math. So 89% incorrectly flagged might mean something to you people. I have to really beat it into my students. So what I say to them is, if I took a 5-year-old and just had him tap this side of the wall or this side of the wall, right? Opioid use disorder, not opioid use disorder. They may be right 50% of the time. We're spending money here for something that's right about 11% of the time. So that was based on Kilby's study.
So it's actually not smarter than a 5-year-old.
No, not smarter than a 5-year-old. Like, I think any of us just on that very simple example, any of us would do way better than the PDMP. There's Dr. Kilby. Like I said, I have her tattooed on my back. Here's what her words were when she was interviewed for the article. The algorithm essentially cannot do what it claims to do. It cannot determine whether writing or denying someone's next prescription will alter their trajectory in terms of addiction. That's her own conclusion from her excellent work on this. And by the way, there are a number of studies that back her up. Yeah.
Can you just say again, she linked it to like opioid deaths or like or just the administrative claims of whether or not there was opioid use disorder? Because to get back to this point of like, we're missing people who die on the streets.
Yeah, the sad, tragic facts about Kilby's study is that it's over inclusive and under inclusive. Mm-hmm. It completely missed people, right, who actually are at risk or did develop opioid use disorder or had something. Completely missed those people because of these characteristics that it's studying and not studying. And then it flagged a whole bunch of people who are legacy pain, generally were middle-aged women who were legacy pain patients who had a lot of the characteristics I told you about that fit the box, right? They often give really, really high risk scores. Another group of people that were with cancer, we talked about that. Another group of people were people who have like really complex healthcare conditions like connective tissue disorders that often have a lot of comorbidities, that kind of stuff where they have like they dislocate themselves a lot. So they're going in for acute care a lot. So they need like that kind of pain management. They have pain management over here. So people with those kinds of conditions were almost always flagged as having opioid use disorder, notwithstanding the fact that we knew for sure they didn't because they had been safely on opioids for 20 years. And if you know anything about Schedule II prescribing, they're randomly drug tested constantly. They're subjected to pill counts constantly. These people can't even go out of town. They sign opioid treatment contracts. You can know for sure that these people were following their medication regimen without any sort of red flags, but they were red flagged by the system. So that's the kind of stuff she was looking at.
I'm just saying that it might have like the 11 only detected 11%, like.
It was only right 11% of the time,
but
whether
some
it
of
was
those
flagging
people-
you or not.
Right. But some of the people who got flagged who didn't look like they had opioid use disorder might have had it if they like had a terrible overdose on the streets and didn't get into the system.
Correct.
As opioid use disorder. But we don't know that, we don't know that piece of data.
That's right.
We don't know how much that was missed.
Absolutely not.
Okay, so because it could have, I'm with you 100%, but it could have potentially flagged people correctly, even if in her data it didn't show up as correct, right?
That's absolutely
If they had an
possible.
OD somewhere
Right.
else and it just didn't get.
That's absolutely possible. And that's the other thing about that is, again, we're not capturing that data in any of these systems so that
Correct.
we can, which reinforces the earlier point. But your point is well taken. That's absolutely right.
Mhm.
No way to know, frankly. Yeah. The other thing that is really important here from what we do know from these like experiments and studies is there's been over a dozen studies now that have linked the use of PDMPs to increase mortality or morbidity around overdose deaths. And this is just one example from one. Look, this was just published this past October. Here's a quote from this. Mandatory prescription drug monitoring program had no relationship with overdose mortality, was associated with increased overall prescription and non-prescription overdose mortality in between state sensitivity analysis. So it's not actually help. There's very little evidence that these things help. There's a lot of evidence that they don't. And again, this isn't scientific. I'm not a scientist, but you can also believe your own eyes. I mean, peak prescribing of opioid prescriptions in the United States was around 2010. And that year we had about 23,000, at least from what we know. And again, this is the CDC data, 23,000 overdose deaths in the United States. We're back at 1993 levels now, and we're setting a record every single year. So something is happening, and this is not helping. If your outcome measure is mine, which is how many people live, how many people make it across the finish line. If your outcome measure is how many doctors prescribe how many pills and this kind of stuff, okay. But my outcome measure is what are the health outcomes from the policy choices that we are making. And this is a huge loss as far as
doesn't that overlook so slightly? That may overlook the dynamics of the system that we're in. The overprescribing, terrible overprescribing, at least partly led to, as you pointed out, switching to street drugs. So all these people were overprescribed. So you have a iatrogenic effect, which is fueling the opioid and now the fentanyl epidemic, which leads to those overdoses. Now, maybe we should be doing something different, but there was a real urgent need to suppress opioid prescriptions from physicians because that was at least partly causing and fueling this deaths we see now. So you're complaining by saying, look, we suppressed opioid prescriptions, but we didn't suppress opioid-related deaths. But I think it takes a different mechanism. It takes something different to suppress those opioid-related deaths, the street opioid-related deaths.
To the extent that you believe that overprescribing is the primary driver here, not that, like, as some people have suggested, diseases of despair, economic conditions, and all these other things, but let's just focus on that. To the extent that you believe that, the absolute worst thing you could do was kick a bunch of people out of the system really fast to get opioid prescribing down. This is an FDA-approved drug. The deaths were way lower at the time. You never want someone to switch to heroin or street fentanyl. So there should have been an intervention that avoided that instead of an intervention that we knew for sure would create that dynamic. And these prescription drug monitoring programs is a kind of intervention that creates that dynamic, just like prohibitionist type policies always have throughout US history.
Right. Through this full time period, buprenorphine was still under a waiver situation.
That's right.
And advanced practice nurses and physician assistants couldn't get waivers. They could prescribe OxyContin to their heart's content, but they couldn't even prescribe you for treating.
People
opioid
often
use
ask me,
disorder.
like, what would you have done different? And my answer to that question is quite simple, which is that we should have kept people in the system, right? And had warm handoffs to evidence-based practices that actually work. Cutting people off, force tapering them, etc., is absolutely not acceptable. And that's medicine's position, not mine. I'm not a medical doctor, and just agitates and aggravates an already bad situation. It's particularly bad if you think that this was iatrogenic. If you think this was caused by medical practices, it's particularly terrible that this was the intervention. Because that is medicine causing the next problem, right? And by the way, I don't blame doctors. I literally blame this on federal and state policies and laws, and particularly our constant approach in the United States to go with a supply side law enforcement. This is what law enforcement wanted. This is a law enforcement funded and driven policy that I'm complaining about
I
here.
don't think that's right. I mean, you have to go back in time. This is what everybody wants.
Can I
Everybody
suggest,
wants
can I
it.
suggest
But-
one additional nuance that might help with this
Yeah.
discussion, which is that there's and I don't know enough about this epidemic and how it goes, but my understanding is that there's the initiation of opioid use, and then there's the continuation of opioid use. And what you're worried about, Joe, I think is the initiation point is like, that's part of like if we could stop the initiation through not having people get prescribed it if there's an alternative pain medication,
And we
that
probably
would
did,
actually,
by the way.
so that would actually really, that would really, really help. What I think your point is that once people are addicted, or once people are, already have access, if all of a sudden the solution is then to cut them off, then they're going to go to street drugs, and you've totally done the wrong thing. So I think it's just what the solution is. It depends on what stage you are, like what stage the patient is.
Sure,
And
what
so
part of
there's
the balloon
different
do you want to
policy
squeeze?
mechanisms.
But when you squeeze one part, you squeeze out the other. You even enlarge the other part.
For me, I cannot justify going from 20,000 deaths to 100,000 deaths. The policy is a failure. But I would also say that, and this is the more
But
controversial
it's not only, okay, fentanyl and carfentanil have a lot to do with that. It's part of that growth. Part of those deaths are related to much more powerful street drugs available.
No,
now
I
than
totally
over.
agree with that.
Okay, so that's not related to that's obviously the overprescribing drove people to those drugs, but those other drugs became available.
Right, and whatever's available is what people use, and that is drug policy people would have very little sympathy for any of these arguments, because one of the other things that's known that people don't like to talk about in the studies is that a very small percentage of people initiated on opioids and developed opioid disorder through like I'm just gonna give you the classic, like the lacrosse player sprains his ankle, mom takes him in, and they give him a ton of opioids, in the emergency room, and suddenly the person's addicted to opioid use disorder. Huge percentage of these people, I'm talking over 80+%, even if you believe the studies that are most generous to the iatrogenic argument, had previous drug misuse and drug use issues before they were prescribed an opioid. They were using heroin, they were using cocaine, they were using other things. So, right, these were people that were already, there's a bunch of studies, and most of the studies show that only about between 1% and 8% of people ever developed opioid use disorder who were naive to drug use problems or drug misuse problems when they were prescribed that first opioid. So you have to factor that in. So I was just adding another layer of nuance. It's not part of this argument because it doesn't need to be. This is an intervention where no one can show me this has helped anything besides push down prescribing.
So
I'm not the one doing these peer-reviewed published studies and all these journals. Those are PhDs and scientists and medical doctors. People just don't like this argument. I always get this pushback. Always.
So one thing I'm curious about, and this kind of a family experience story, is how do payers use this, specifically like Medicare? So I had a family member who is stably managed with significant orthopedic issues, stably managed on whatever opioid.
Right.
And at some point, the physician said, basically, I need to cut you off and send you to a specialist because I'm having, and I believe it would have been Medicare or Medicare Advantage or the, Part D.
Right.
whatever, is actually giving me flack about my prescribing
Hmm.
and telling me that I need to taper people.
Right.
And this family member this family member themselves was a probation officer and was like, what am I going to do? Maybe I'm going to do medical marijuana, right? This is somebody who never smoked pot in his life. And the answer was, actually, if you pay cash, then I'll prescribe it and you pay cash if you're not going through your prescription plan, because that's where the provider was getting the heat, was actually from the prescription drug payer, not from the PDMP at that time. And I was just like, what is going on with this? Anyway.
So first of all, the interesting thing about that dynamic is in that person's narcs care score is going to go through the roof,
Right,
even though they're
exactly.
stable.
Of course.
Right.
But,
So
and
again,
the
we're
thing is that
forcing
they're stable, right?
Right.
They're stable pain management, and knowing this as a family member, I was
Yep.
super puzzled, because I'm like, this person can hardly walk because of their level of pain.
Right.
And so it was like, wait a minute, what is the system that's going to cut them off? And then how does paying cash evade that system? Or is that just the physician is afraid of getting, but then I think the physician is.
They wouldn't
anyway,
be able to
I'm
evade
totally-
PDMP that way, but a lot of states used, right? Like, so the states were pressured again here too, right? And the federal government to say, we're doing something. We're doing something about, right? Where the
And
opioid
or the
crisis.
payer was.
So Medicaid
involved.
and Medicare
Probably
absolutely cracked down
pushing it.
on providers as well.
Yeah.
So it came from all directions. The state
Yeah.
licensing boards did,
Yeah, I felt
their
sorry
payers
for the physician
did.
too.
the DEA did. I mean, the states at the state and federal level. This became demonized really quickly, and what we used was blunt force instruments that never work.
Yeah.
Clubs.
Yeah.
And,
So
and
what
that's
the
it. There's nothing
So
else.
the payers are using these
Especially
NARC
Medicaid.
scores and whatever,
And especially Medicaid and
and
Medicare.
that might even be separate from what's happening in law enforcement.
Absolutely.
Right. Oh, and they're probably using NARC's care, and this individual was in California, which is using our homegrown system.
Right.
So maybe it wasn't even flagged in the California system, it was getting flagged on a federal.
Yeah, because California, I don't know what California does not use this particular algorithm, which is really unusual. It's like 1 of 7 or 8
Yeah.
states
Huh.
that doesn't use it.
Okay.
You know, although California, what I like about California as an example, and I'm going to make people hate me even more when I say this, is that California, because it has the longest running continuous system, it's true to the PDMP, which is that it's a law enforcement tool. It's in the California Attorney General's office. It's not in a health department. Okay, so it's like just being honest about the roots here. The other thing I would say,
do they also have a black box, or can you see what their algorithm is?
I don't know what they have
For California.
they have a one-off vendor that they hired years ago.
So it's also a black box.
Yeah, yeah. But they don't, in all fairness to California, they don't use dark scares, so I can't pick on them that way. The other thing I would ask you, and I say this to people all the time, to think about when you get upset about what I'm saying here, and I completely understand, is what other clinical diagnostic tool do you know of that was generated by and paid for by federal law enforcement agencies? Like, can you think of any? Because I haven't been able to find a single other tool that is used in clinical diagnostic work that was funded by federal law enforcement. So just something else to think about as far as like how unusual some of this stuff is. All right, I'm going to take my time. So I should actually take questions now, shouldn't I?
Well, we've been
interjecting.
Well,
I
I'll-
guess we should ask Kat whether there are
Yeah.
questions from the folks who are.
If not, I'll go
Virtual.
and then, but if someone pops up, will you just let me know? All right, the other thing I want to talk about, and I spent a lot of time on this, and I have learned a lot about this over time, is the longstanding sex and race discrimination and pain management. Then this just piles on for some people, okay? So research demonstrates that clinicians have long undertreated pain in women and Black patients. Qualitative research that focuses on physician opinions about pain patients, as well as quantitative studies that examine disparities in pain medication prescribing, establish that clinicians find both of these groups of patients untrustworthy, but they do so for really different reasons. Okay, clinicians believe that women are prone to exaggerate or quotes unquote catastrophize their pain. They frequently attribute women's complaints about pain as psychosomatic or symptomatic of a psychiatric disorder. And as a result, the studies show that women are more likely than men to be prescribed a psychotropic rather than an analgesic when they raise pain complaints in the treatment setting. Black patients, on the other hand, are grossly undertreated for their pain due to embarrassingly false racial mythologies that were used to justify slavery. And I've chronicled those myths in my paper. I'm really reticent to repeat them here. But they range from things like Black people have different nerve endings in their bodies, which, or Black people can withstand more pain. That often people will say stuff like Black people gain superhuman powers when they take drugs, or they're more likely to develop a drug use disorder. None of these things are true. But there are some studies that show that even medical residents continue to this day to harbor, and it's really, I know it's hard to believe, but it's true. In addition, and this is anecdotal, I completely understand, but I wanted to share it. I interviewed several Black women who've had major surgeries, including hysterectomies and double mastectomies, when I was working on these papers. And many of them reported they were sent home mere hours after those highly invasive procedures with nothing more than ibuprofen. And this is particularly problematic given that the most common surgery in the United States is hysterectomy. And I often say at this juncture, that the name of that surgery tells you quite a bit about what the practice of medicine have thought about women over time. There's one thing, however, that has been more troubling to me than what I've been talking about so far, which is that unfortunately this was framed, and this is really interesting in the debate that we're having right now. People acknowledged that Black people and women were undertreated for pain, and that Black people in particular were grossly undertreated for pain. And they said that the popular media for many people was they were lucky and they should be grateful. So here's an article from the New York Times. I'm not kidding. You can read this yourself. You can see the pictures of these men on here, so you can see that they look like at least white men, think that they are, published in 2019, a rare case where racial biases protected African Americans, and they felt confident writing this, and it got published in the New York Times. So it goes without saying there are zero documented examples of rampant racial discrimination ever working out in the favor of Black patients, including here. And why this upsets me so bad is it actually ignores the fact that the current crisis has disparately impacted African Americans. This is a SAMHSA study here, and you can see in this report, SAMHSA explains Black Americans suffered the highest rate of illicit fentanyl overdose deaths of any American population from 2011 to 2016. And given the underprescribing with Black patients, this should raise questions for physicians about our interventions here, but I'll move on because we've already talked about that. This is also a little bit more recent data. This one is from 2018 and 2019, and it shows the difference. And what you can see here is even though white opioid overdose deaths decreased by 2% during this time period, they spiked by 38% in Black populations during that 12-month time period. So I was particularly agitated to see that article come out in 2019 when there was all this other data. So I'll stop here and just say that my proposal was that the FDA ought to run, and I'll put the criteria up. They have a regulatory framework that they evaluate clinical diagnostic tools with, called their software as a medical device. That's SAMD regulatory framework. And I end up arguing in the paper based on all the studies that have been done, the Kilby modeling study, that NARCS care would fail all three of these criteria. Is there a valid clinical association between your output and your targeted clinical condition? And the targeted clinical condition here is determining whether someone's going to develop opioid use disorder or suffer an overdose. Does your software correctly process input data to generate accurate, reliable, and precise output data? No. And does your software accurately, reliably, and precisely, does your output data, achieve your intended purpose and your target population in the context of clinical care? And my argument will be, if it's to reduce overdose deaths, no. If it's to appropriately flag people who need a warm handoff to addiction medicine, no. And if it has been to avoid pain and suffering in late stage cancer patients and people in hospice care, the answer is no. So I would argue, and do argue in my paper, that NARCS care fails all three criteria, and I have implored the FDA to do an external validation under its criteria. And that's all I have.
Did they get back to you on it?
No, but you know who is interested in this, and I've got to be careful what I say, but is the U.S. Department of Justice. And for a long time, under the ADA and Section 1557 of the Accountable Care Act, the Federal Department of Justice, under multiple administrations dating back to Obama, have taken the position that it's inappropriate and violates the ADA to just draw a bright line rule around things, right? Like, so to just say, like, anybody like this does not get treatment, or we won't take any patients with XYZ condition. So if you have a system like this that says anybody with an I'm just making this up, but over a 650 score cannot be prescribed in our treatment setting, that but without doing an independent assessment of that particular patient and their underlying conditions and where they live and all of their particular factors, having a policy like that violates the ADA. The Federal Department of Justice has agreed with that, and they have actually made their big statement about this a couple of years ago with folks that wouldn't take people who actually had opioid disorder into their treatment setting. And this happened in Virginia, and they ended into a big settlement agreement. And you can't have a policy that says we just won't take on a patient with opioid use disorder, and said it was a violation of the ADA. So the disability rights section of the Federal Department of Justice has some interest in how these PDMPs are being used when they have these kind of bright line of rules. And you can imagine getting away from individual assessments and things like that. It's problematic for clinicians.
But you know, and I mean, that's encouraging.
Yeah.
But if the system is wrong as often as Kilby's research suggests it is, then it seems to me there's a lot of energy then doing reviews on patients for whom that's really not warranted. I mean, if you had something that was accurate, even 50% and certainly 70, 75, okay, then maybe this is a tool that is helping you draw some inferences and perhaps flag patients who really would benefit from slow taper or transition to buprenorphine. But if you're wrong that many times, I mean, wrong that often.
It's shocking. It's shocking, and this is in all 50 states now. Missouri finally caved, which is like the show me state was the holdout state, and apparently that was for like reasons that none of us can understand unless we're from the Midwest. But they resisted the PDMP, but they enacted legislation this summer. They have had one in St. Louis County for quite some time, and they're standing up one statewide. So there's operational PDMPs everywhere except for Missouri, which has one in its biggest county or its most populated county, and they're working on building theirs out now. So my only point I make about that is that they're ubiquitous, and there's so much pressure on a clinician. Again, they have to look at it. It's the state mandates that they have to look at it if they're going to prescribe an opioid, and so that flag is staring you in the face. And then once you're in that system as a controlled substance prescriber, you can, like I said, walk in I've heard this scenario, and I've had clinicians tell me this that were being really honest. I walk in the morning and I just get this email, and I'm like, oh, snap, like, and they know, and it says this has been sent to your, professional licensing board and whoever it's been sent to. They see that stuff. So this is like actively happening in real time, and it's had a tremendous impact on people, and clinicians when they're interviewed say, yeah, it does have a huge impact on me. So I imagine the DA come knocking on your door would have a big impact on you.
So tell us about the Supreme Court case.
Okay.
The last
Okay, this is the case, just so people know. See ya. And I know I'm out of time. And I apologize about that, but I really appreciate the questions. We had a case this summer, Ruan versus United States. This involved a controlled substance prescriber, a pain management practice in Alabama, in fact, and these doctors were indicted by the DA based on PDMP data. They were indicted for federal felony drug distribution. And every time you make a single prescription is a single charge, and those charges carry with them 20-year sentences and $1 million fine. Okay, so you can imagine what the doctors were up against in this situation. For a long time in the United States, the rule had been, under the Controlled Substance Act, you can't actually charge someone who's authorized to prescribe a controlled substance, meaning you have a DA registration, right? For felony criminal distribution, like a drug dealer, right? A traditional or conventional drug dealer, as long as they believed in good faith, they had a legitimate medical purpose for that prescription. Well, over time and throughout this opiate crisis, and you can see how much this impacts all of our thinking. Here's the legal system again, doing us all a disservice. In several states, including where Alabama is located in the 11th Circuit, which includes Florida, Georgia, and Alabama, that circuit had eliminated this good faith defense. So what it effectively did from a legal perspective, and I'll say this as simple as possible because it'll be better if I just don't even look at anything else, is it took a federal criminal statute that carries 20 years per count and $1 million fine and converted it into simple negligence. Because if you were just wrong, if you were just outside the standard of care and you lose that good faith defense and there's no mens rea left anymore, we're now down to like a medical malpractice claim. And one of the things we were able to argue in this case, and I teach torts, thank God, was it's actually worse than that. it's harder for a plaintiff to win a medical malpractice case with the exact same facts here, because that plaintiff has to prove negligence, which duty, breach, causation, damages. They have to have actually been harmed.
Damages.
These patients don't have to be harmed at all, right? All the DEA has to say is you shouldn't have prescribed them the opioid in the first place. That was outside the standard of care. They don't have to prove any harm to any patients at the end of the day. So we argued this is actually worse than the general civil system. In the state of Alabama, he wouldn't have been able to be prosecuted for this because they couldn't establish harm to any of the patients. And we were able to succeed now, I know, in the case.
And thus more recently than they do a sting with to try to get,
Yeah, but these were, and one of the reasons why we got involved in this case is because we knew this was going on because they used it to PDMP. So we were trying to use our expertise there to show that like there was no point in putting doctors in this position. So anyway, that's sort of kind of what we've been up to on this stuff. I understand that it can be very, very, very upsetting. It's even more difficult to get lawyers to listen to me than it is doctors. So I appreciate you guys and scientists. So I appreciate you guys at least.
let's see, psychology, economics, statistics. Yeah, no doctors.
No doctors?
Public health.
I didn't get a single.
Naomi.
I was like, I didn't get a single doctor over here.
Naomi.
No.
But sciencey people tend to be more open-minded about it a little bit. But I just think that, this narrative was worked on us so bad that we just keep making the same mistakes over and over again.
I think we have one more question.
Yeah, sorry, just related to, I was going to ask it just before you went on this, but so in terms of reducing the number of pill mills,
Yeah.
does PDMPs actually succeed, or does it just suppress all the legitimate doctors from prescribing?
Well, it's very difficult to say with pill mills because first of all, it's like most people, and I've said this, pill mills are super obvious. Like that was the law enforcement could like discover pill mills by just pulling into like the parking lot and sitting there and saying, "Oh, why is
McKesson could have figured that out."
I lived in West Virginia and I taught at WVU was my first teaching job before I went to Seton Hall and then came here. And you couldn't. So that was like Florida and West Virginia had really a high number of pill mills. You could absolutely knew this little tiny podunk pharmacy had 50 cars in it. People are going through a drive-through and there's out-of-state plates and stuff. And then people are stopping and making, all you had to do was drive by it and you could call in the pill mill. But I will say this, certainly PDMP sort of picked up pill mills, no doubt about it. And they did. But there was a million other tactics that could have been used on pill mills too, or they could have just targeted those folks and left everybody else alone, or asked people to do different things. But there's no pill mills left, and if you're running a pill mill and getting away with it right now, God bless. You really have skills because there's so much, and I don't even say that there's so much surveillance and things like this. But yeah, a PDMP would be great at picking up a pill mill.
They're just running like pot dispensaries now.
Yeah, that's right.
Yeah.
That's right. That's exactly right. And there are several states that actually require dispensaries that are when you have a medical marijuana card. So don't go to a dispensary. You guys in California have a choice, right? In some states you don't.
You don't have to be registered.
Right. You can just go buy pot here, right?
Yeah, you can. Yeah, you get somebody to write you a recommendation.
You don't want that though, because those records, some states are calling that like basically a prescription dispensation, and they actually put them in the GMP.
Oh, here they're not.
Yeah.
Yeah, I don't think
there's
they're
like
recorded
12 states, and I've been surprised. I've seen this. That's been a recent thing. I've seen
Yeah.
surprised now, like require to see if you're, you have a marijuana.
Oh, but in some of the
Registration.
states that have the medical, if you have the medical card,
Yeah.
it's medical, and therefore there's no sales tax.
Oh, that's the better.
So
But you go in the
so some
PDMP.
people are willing to do that because you get a better price for your
that's
weed.
right.
So
But that's that's a tough choice.
Mhm.
California does not track it yet. There's a TTAC. There's a website you can look up to kind of see what's going on in the states. They track all 50 states. Brandeis University runs it.
maybe they'll unschedule marijuana someday.
Yes. Well, thank you all for coming.